Thank you for joining Cancer Support Community Atlanta for this program. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. If this is your first time participating, we invite you to complete a new attendee form to stay connected to all future programs.
All right, I think we will go ahead and get started. Welcome, everyone. I am going to be admitting a few more people as we go, but it is past 12, so I think we'll go ahead and get started. Again, this is Emily Brown, the Program Director at Cancer Support Community Atlanta. Thank you for joining us today on this program on MPNs presented by Dr. Tatyana Sklyar. You can go to the next slide. This program is brought to you today by Cancer Support Community Atlanta. If you are not a current member at CSC Atlanta, we invite you to join us. Let me know in the chat box and we can send you one of our new attendee forms. We have many programs available for free. We are the local affiliate in Atlanta of the world's largest provider of free support services for people with cancer and their caregivers. So we welcome you to join us in our program, so I'll tell you a little bit more about. Next slide, please. Currently, we are offering all of our programs virtually. And if you'll click a couple more times, these will pop up. We offer virtual support groups, stress reduction classes, exercise programs, nutrition programs, and education. And again, currently all these programs are offered virtually and are free to anyone who's been affected by cancer. Here is an example of two of the support groups we provide. We currently have a weekly support group that is open to anyone who has a cancer diagnosis that meets every Monday at 2:30, again, virtually over Zoom, as well as a family and friends, that's our caregiver support group that meets the second and fourth Monday of the month at 12:30. So we invite you and your family members to join our support groups. If you're interested, you just email me, emily@cscatlanta.org, and I will be happy to get you set up in one of our groups. Next slide, please. This is a list of our weekly stress reduction classes. So as you can see, we offer many classes on a weekly basis. All of these, again, are free to anyone who's been affected by cancer. Today, we are going to be having a guided meditation at the end of this program. Every Friday, we offer a 30-minute guided meditation that is open to anyone who's been affected by cancer and is just a great way to end your week feeling good about the weekend. All right, next slide, please. And of course, we do have our regular education and nutrition programs. Next week, we will have a cooking demonstration on immune boosting soups. We do these cooking demonstrations every month. They are live demonstrations from the CSC kitchen that you can join us virtually. This month, the theme is immune boosting soups, and that will be on October 13th at 11 a.m. So if you'd like to join, you can go on our website, cscatlanta.org, and register there, or email me, emily@cscatlanta.org, and I can send you information to get registered for that. Next slide, please. All right, so without further ado, I'll go ahead and introduce our presenter for today. Dr. Tatyana Sklyar is a board-certified physician in medical oncology, hematology, and internal medicine. She received her medical degree at Russia State Medical University in Moscow, Russia. She completed both her residency and fellowship at the Allegheny Health Network in Pittsburgh, Pennsylvania. She is a member of the American Society of Clinical Oncology and the American Society of Hematology. She has a clinical interest in breast cancer, lung cancer, colon cancer, hematologic malignancies, and benign hematology. So thank you so much, Dr. Sklyar, for doing this presentation for us today. I will let you go ahead and take over.
And hello, everyone. Thank you for coming. And today we are going to talk about myeloproliferative disorders, which are shortly MPN, or myeloproliferative neoplasm. So what are MPNs? MPNs are a type of blood cancer. So that means that they start in the bone marrow where all our blood cells are formed. Myela means bone marrow, and proliferative means too many cells are made in a bone marrow. We are going to talk about three main or classic types, which are polycythemia vera or PV, essential thrombocythemia or ET, and myelofibrosis or MF. So first, let's look on our blood, what kind of blood cells we have there. We have white blood cells, and there are different subtypes, and white blood cells are responsible to take care or treat infection, inflammation. They also participate in allergic reactions. We also have red blood cells. The main function is to carry hemoglobin, which attaches to oxygen and carries oxygen around our body. Platelets are little pieces of cells that are responsible to stop bleeding or create blood clots. So how do we know how many cells do we have? We have this blood work test. It's called complete blood count or CBC. This is just an example of normal CBC. You can see from top to bottom WBC, which are white blood cell counts are reported, and they typically should be between 4 and 10. RBC or red blood cell counts, we usually look on hemoglobin, which better represent the RBC function, and normal for females about 12 to 14, for males a little bit higher, 14 to 16. Hematocrit is just a calculated number which show the volume of red blood cells in percentage of volume of red blood cells. And even though we don't use it frequently in myeloproliferative disorders, especially in polycythemia vera, that's very important number. So MCV means size of cells, and you can see the number of platelets. The last line, there should be about 140 to about 450 approximately. So how we diagnose MPN, or when we concerned that someone might have MPN? The most commonly, patients present with abnormal blood counts, which we can see on the lab test, laboratory work. In polycythemia vera, we commonly see elevated hemoglobin that make us concerned that patient might have this disorder. In essential thrombocythemia, platelets can be elevated, will be elevated, and in myelofibrosis, there are different findings. Most commonly, patient will present with elevated white blood cell counts, but also they can have anemia or elevated platelets. So there may be multiple findings, or in general, just abnormal blood counts. We do then additional blood work, which include EPO, which is erythropoietin. That's the substance that our kidneys produce to regulate anemia level. So that would be important for our blood test. We also check blood for certain mutations that can be associated with myeloproliferative disorders. And the most common is JAK2 mutation. The next step is a bone marrow biopsy, and most of the patients, when concerned about myeloproliferative disorders, will have a bone marrow biopsy. So this procedure typically done in clinic. It also can be done in the hospital. The bone marrow sample is taken from really thick pelvic bones. It's called iliac crest, and the area is numb with lidocaine. It's done under local anesthesia. You can see a little representation here with a needle. We go with the needle through the bone. We get the liquid part of the bone marrow, and then we turn needle in certain way to get a little piece of the bone marrow. And all of this will be examined under microscope in order to determine if any abnormality exists. I put a little slide here so to explain what we're looking when we look on bone marrow. The largest picture is a normal bone marrow. You can see the large white circles. This is fat tissue. So in our bone marrow, we have to have a certain amount of fat tissue, and the little blue dots, those are cells that made in the bone marrow. They're all different kind of cells. Some of them already ready to go to your blood, some of them just precursors. And on smaller pictures, we can see abnormal bone marrow samples, which on slide A, it's essential thrombocythemia. There are some large pink spots. Those are precursors of platelets. They look abnormal. That's what we're looking for the diagnosis. On slide B, you can just see that there are too many cells are made that represent polycythemia vera. And slide C shows a picture with myelofibrosis, and it shows that cells are abnormal, and also there is some scarring of fibrosis of the bone marrow, and that's why we call it, of course, myelofibrosis. Patient may also present with symptoms which most commonly include fatigue, headaches, early satiety, abdominal discomfort, itching, weight loss, fevers, bone achiness, or night sweats. Why it's important to diagnose this type of disorders on time and treat them appropriately, because these disorders can lead to clotting or creating blood clots, bleeding, or it's possible progression to more aggressive disease, such as polycythemia vera or essential thrombocythemia. They can progress to myelofibrosis, and myelofibrosis can also progress to AML, which is acute myeloid leukemia. This is just slide show you a summary, what kind of MPNs we're talking about. Vera is the most common disorder. 100,000 patients have it currently in the US. Essential thrombocythemia is about 80,000, and myelofibrosis is the least common. About 20,000 of patients have it. Median age of diagnosis, most patients will be 60 or over. Bone marrow abnormalities, we talked a little bit about, or blood cells abnormalities as well. Median survival, the best median survival is in essential thrombocythemia. Patients basically have a normal survival, so it's not affected by the disease. Polycythemia vera, a little bit less, about 16 years. And myelofibrosis survival varies based on risk. We'll talk about it later, but in overall between 2 and 12 years. And the JAK2 mutation, which we already mentioned, almost all the patients with polycythemia vera will have JAK2 mutation. It's part of diagnosis. About half of the patients in myelofibrosis or essential thrombocythemia will have this mutation. So let's talk about each disease separately. First is polycythemia vera or PV. What that means, polycythemia is opposite to anemia. If anemia is when you have low hemoglobin, the polycythemia just means that you have high hemoglobin. And vera, it's basically true polycythemia. That means that it starts in the bone marrow. Too many cells are made in the bone marrow during this, because of this disorder. Blood work will show elevated hemoglobin with over 16 in female, in 16.5 in males. When we check erythropoietin level, we find that erythropoietin level is low. That means that bone marrow producing anemia without really body requiring it. When someone presents with elevated hemoglobin, we also need to consider other disorders. We don't have to think that it's necessary the bone marrow disorder from the beginning. Some other disorders that can cause also elevated hemoglobin will lead to what we call secondary polycythemia. And this causes or disorders can be extensive testosterone use, excessive testosterone use, lung disorders such as COPD, obstructive sleep apnea, some other lung disorders when your body just not getting enough oxygen. And it happens rarely, but liver or kidney tumors can also produce erythropoietin and cause elevated hemoglobin. Some iron overload disorders can lead to elevated hemoglobin. So all of this needs to be rolled out. Patient might have symptoms such as headaches, visual changes, dizziness, fatigue, itchiness after showers, unexplained blood clots, abdominal discomfort, or early satiety. When someone diagnosed with polycythemia vera, we do risk assessment, and we divide patients into low risk or high risk. Low risk patients 60 or less years old with no history of blood clots. And if patients over 60 years old or have history of blood clots, we consider them to be high risk. Everyone with polycythemia vera should receive phlebotomy, which is regular blood draws with goal hematocrit less than 45. So we've been talking about this hematocrit number in polycythemia vera. It's very important to keep it less than 45 because over 45, hematocrit can be associated with increased risk of blood clots and other complications of this disease. Patients need to be on low dose aspirin, which is antiplatelets agent, and again, it decreases the risk of blood clots. Also, it's important to manage cardiovascular risk factors, such as hypertension, elevated cholesterol levels, smoking, and etc. High-risk patients require additional treatment to decrease their blood counts production. And the most commonly we use oral medication, which is called hydroxyurea or Hydrea. This medication basically decreases your blood counts, decrease the production of all blood counts by your bone marrow, taken orally daily, and blood work needs to be done on a regular basis to make sure that blood counts stay in the range that's acceptable. Interferon, another medication that is used for polycythemia vera, it's injections. There are different types of interferon. Most of them you require injection every 2 weeks or every week. Another medication that can be used from the beginning. We don't use it that frequently as for now because of the side effects. Most people will have flu-like symptoms with interferon use, but new interferons better tolerated, and I think in future it's going to be used more frequently and more in more patients. Ruxolitinib, another oral drug that targets JAK2 mutation. Right now it's approved for as a second choice if patient cannot tolerate hydroxyurea for any reason. Okay, the next disease is essential thrombocythemia, or ET. In this disorder, too many platelets are produced by bone marrow, and on blood work, we can see elevated platelet count over 50,000. Differential diagnosis includes or other disorders that we need to exclude prior to diagnosis is iron deficiency. We frequently see elevated platelet count reactive in iron deficiency, and also reactive thrombocytosis in case of infection or inflammation. Patient might have symptoms such as fatigue, headaches, dizziness, visual problems, blood clots, unexplained bleeding, miscarriages. In essential thrombocythemia, we have 4 actually categories of risk assessment: very low risk, patients 60 or younger.
Tracy, you have a phone call on 1371. Tracy, 1371.
Sorry about it. No history of blood clots, no JAK2 mutation, low risk considered to be again age 60 or younger with no history of blood clot, but patient who have JAK2 mutation. Intermediate risk patient age over 60 with no history of blood clot and no JAK2 mutation. And high risk patients are either with history of blood clots or age over 60 and positive for JAK2 mutation. For treatment, what is important, first we assess risk of bleeding, because patients with platelets above 1 million can be at risk of bleeding. If after that we start everyone on low dose aspirin to prevent blood clots. Also managing cardiovascular risk factors is important. If patients have history of blood clot, they need to be on blood thinners. And high-risk patient, again, will require additional treatment to decrease the production of cells in the bone marrow. And again, hydroxyurea, the most commonly used drug. Again, interferons is another option. If patient failed hydroxyurea and anagrelide, which is also oral drug, is used. And the last disease is myelofibrosis, which is basically scarring on bone marrow. So bone marrow cannot produce enough cells because of this scarring, and spleen, that's what we have on this picture. That's where the spleen located. It's another blood organ. Sometimes it's pick up production of blood cells, it's getting large, and that's what mostly causing symptoms in this disease. Patient can be with previous history of polycythemia vera or essential thrombocythemia. Blood work can show elevated white blood cell counts, anemia, elevated platelets, but actually that's not necessary. The blood work can show also low platelets or low white blood cell counts, but in general, blood counts will be affected. And enlarged spleen, the symptoms, again, fatigue, fullness after eating, mostly because of this enlarged spleen, or discomfort on the ribs on the left side. This can be associated also with weight loss, low-grade fevers, night sweats, and bone pain. For myelofibrosis risk assessment, a little bit more complicated. We use a special risk score assessment, which includes presence of symptoms, white blood cell counts increase, level of anemia, platelet number, number of young blood cells in the bone marrow, which we call blast, and mutations that can be associated with high risk. All of this calculated into the score. And then patients divided into have lower score or high score. Those that with low risk can be just observed or can be on treatment with interferon, ruxolitinib, hydroxyurea, especially if they require the symptom control. High-risk patient, the best and the only curative treatment is stem cell transplant. Ruxolitinib also approved for treatment of high-risk myelofibrosis. Some patient might require only symptoms management, such as anemia management, or if they have enlarged spleen and that cause symptoms, they can have splenic radiation. So the stem cell transplantation is, again, the only curative option for myelofibrosis. It's done in large centers. And particularly for myelofibrosis, the type of the transplant is called allogenic transplant, means that stem cell collected from donor. And donors can be much related donor. That means that likely your siblings, matched by blood type, or a little bit more detailed types. They also can be unrelated donors. Haploidentical means it's either your children or parents. And if no donor can be found, umbilical cord blood can be used. Patients have to be evaluated for transplant eligibility, means they have a good function of heart, lung, liver, kidneys, and they have to be active patients. Stem cell transplantation involves several steps: finding a donor and collection of stem cells from the donor. Next step, patient receive a special preparative regimen, which is a high dose of chemotherapy, and total body radiation can be used additionally. And this is done in order to eradicate disease and cause enough immunosuppression to prevent rejection of donor cells. The next step will be infusion of stem cells. And next step is very important: post-transplant care. Patient will be monitored for prevention of infection. Most people will require blood transfusions, and some people will require treatment of complication of transplant, such as graft versus host disease. And that's it. If you have any questions, this is just a picture of my cat, Cruiser. He always looks like he has some questions.
I love it. Thank you, Dr. Sklyar. We do have some questions I'll get to. I just want to remind everybody, if you do have a question, feel free to submit it to the chat box at the bottom of your screen and we can read those off for you. Also, I'm going to be putting a link to our survey for today's program. If you could take the time to fill out that survey, we'd love to hear from you and any suggestions you have. And of course, stick around for our guided meditation at the completion of the Q&A. All right, first question is, are you seeing an increase in younger patients with MPNs?
We see some young patients with MPNs. I agree. I don't think that necessary increase. I still think that most of the patient who diagnosed will be in this category at age 60, 65.
Okay, thank you.
But I agree that we see patients in their 30s, even late 20s, which diagnosed with MPNs.
What are your thoughts about treating with interferon versus hydroxyurea, especially for a 34-year-old woman?
Yeah, so yes, I agree that interferon is a great treatment. It's also been shown that it associated with less risk of disease progression, with better overall survival, with better progression-free survival. So there is many benefits of interferon. And the only, I would say, negative use of interferon, that it's make patient very symptomatic. Patient have flu-like symptoms. And
John
given
Paul, Dow 8188. John Paul 8188.
given that and given that MPNs typically diagnosed in population of 60, 65 years old, most patients having problems tolerating it. We do reserve it definitely for younger patients. Someone who is 30 years old, great candidate, because of course, very important to have a good overall survival for patients like that. And they're probably gonna tolerate it better than older patients.
Okay, thank you. And what do you think about having PV and pericarditis?
I would say someone who is diagnosed with polycythemia vera and then have pericarditis, or someone who was diagnosed with pericarditis having elevated hemoglobin.
All right, if anyone else has a question, please feel free to submit it in the chat box now. I have put our survey link in the chat box if you don't mind taking a minute and completing that survey. Somebody, oh, they responded that PV first and then pericarditis.
I'm not sure. I think that needs to be investigated if pericarditis is a result of treatment of polycythemia vera, or is it a complication of thrombosis or bleeding. There are different types of pericarditis, so that would be very important to find out what kind of pericarditis it is and investigate how it can be related to polycythemia, because that's not a common presentation, I would say. So must be something else is going on.
Okay, thank you. We have another question came in. My latest CBC showed elevated white blood cells with elevated platelets, normal iron stores, but I have anemia. Is this a normal finding with MPNs? I've been diagnosed with essential thrombocythemia.
Yes, so now essential thrombocythemia typically presents with elevated platelets, but hemoglobin and white blood cell count should not be affected. Or if someone have picture like that, we always worry about myelofibrosis. Sometimes it's very hard to distinguish these two disorders. So I would recommend everyone who had essential thrombocythemia and abnormal blood counts like that to make sure they have a bone marrow biopsy, because the only way to distinguish these two disorders is to have a bone marrow biopsy.
All right, and I have MDS MPN overlap. What is my best option for treatment?
Okay, so this is a little bit different disorder. It's fairly benign, I would say, disorder in terms of overall survival and risk factors, very low risk of progression to any kind of leukemia or more aggressive disorder. We usually treat it as low risk disease, means we treat it with symptom control only. Most patients will have anemia, so we treat this anemia. If there is any other blood counts affected, it can be treated as well. But in overall, we just need to make sure that patient does not require regular transfusions and kind of like more like a supportive care.
All right, I think that's it for questions. We're getting some thank you in the chat box. Thanks from the people asking the questions. And thank you for bringing up those questions. I'm sure those might have been asked for other people, so I appreciate you speaking up. As you can hear, Dr. Sklyar is currently doing this presentation from her office at work, so I want to be mindful of your time. I'm very grateful that you were able to do this presentation for us today. Any closing thoughts?
Thank you so much for inviting me. I'm really happy to answer everyone's questions, and being explanation of this very complicated blood disorder that sometimes it's very hard to understand and know about your prognosis. So I appreciate everyone for coming and for questions. And again, thank you for inviting me, and you guys have a good day.
All right, thank you. You can go to the next slide and turn your video off, and I'll go ahead and get started with our mindful guided meditation. We have one participant says, we appreciate you taking the time to educate us. Thank you so much.
Thank you.
All right, everyone, just a reminder, we have a survey I've linked in the chat box. If you don't mind taking time to complete that, we'd love to hear your feedback on our presentation today. Now I'm going to get started with our guided meditation portion of this program. Guided meditation is a very helpful practice to help lower stress and any anxiety you might feel either as a patient or as a caregiver. We know that those can be very stress-causing positions to be in. So we offer these guided meditation programs every week, and we invite you to join us. Today I'm going to do a common one on a protective light meditation. So you are welcome to join now. If you'd like to turn off your screen, you can. I've got a picture I thought was just kind of a calming, soothing picture, but it might be more better for your practice if you either closed your eyes or just turned off your screen for the moment as you listen to me guide you through this. All right, everyone find a relaxed position where you are. Again, feel free to turn your camera off if that's more comfortable. You can choose to close your eyes or just lower your gaze down, whichever is more comfortable for you. Let's begin by all taking in a deep breath. And as you exhale, let the tension start to leave your body, counting to take a slow, calm breaths. Mentally scan your body. Take notes of how you feel in this very moment. Focus in on areas that feel tense or uncomfortable and concentrate on relaxing those areas. Feel your body becoming more relaxed. Slowly releasing tension, letting go of stress. As you relax your body, I want you to visualize a protective light. Imagine that there is a protective light shining around your body, almost as if you are glowing. The light can keep you safe right now from stress, tension, worries, and any other problem that seems to be bothering you. Picture in your mind being surrounded by light. It can be a warm light or it can be cool. However it glows, feel how calm and secure, and feel this protective light as it surrounds you. This light is like a shield, deflecting anything that is not good. It is like an armor that can protect you and help you feel completely at ease. Imagine your body being surrounded by your protective light, from your head to your feet. Turn your attention to your feet. Let any tension there go, feeling how relaxed and maybe even tingly your feet feel. Notice that your feet are surrounded by your protective light. Allow this light to move upward to your ankles and lower legs. Feel your lower legs relaxing, surrounded by light. Soft, heavy, relaxed. Now your upper legs are relaxed and surrounded by light. Warm and completely at ease. Allow this light to support you, giving your legs the much-needed rest from a daily task of keeping you grounded. Now turn your attention to your hands. Feel the tension leave as your hands become relaxed. limp, heavy, along with your wrists and arms, all surrounded and protected by this light. Feel the light move inward, relaxing in the core of your body, starting at your stomach and flowing outward. Feel the light flowing from the center of your body out to your back, chest, hips, illuminating your body. Now your whole being is enclosed in a shield of glowing light. Allow the calming sensation to continue to flow through your body, upward to your neck and shoulders, all the way to the top of your head. Feel your face relaxing, letting go of tension, and the protective light glowing warmly on your face, on your whole body. You are surrounded from your head to your toe in light. Notice that there might still be some areas of tension in your body, some worries remaining in your mind. You might even be able to picture these areas of tension as dark areas. Envision the dark tension being drawn out of your body by the protective light. Feel the worries and stress leaving your body and mind as they are banished from your body. This protective light is like a magnet, drawing the dark tension of your body away. Repelled by the light, once the tension has left your body, it is gone and unable to return. The light also works as a magnet for good, peaceful thoughts, attracting harmony to you. Feel the protective light drawing any tension and bringing forth relaxation, shielding and protecting you while helping you to feel even more at peace. Enjoy the feeling of being safe and protected by your shield of light. You are calm, peaceful, relaxed, and safe. Now it's time to return to your day. Remember that you can imagine this protective light again anytime you need to, and can repel the stress and tension and restore yourself. Focus again on your breathing. Take a deep breath in and out. Now turn your attention to your body reawakening. Gently move your body a little, feeling your muscles waking up. You can stretch if you'd like, and allow your mind to become fully awake and alert while still feeling relaxed. When you are ready, open your eyes and look back, fully awake, energized, and calm. Take a moment to enjoy the quiet peace that surrounds you. Thank you all for joining us today. We welcome you to join all future education, nutrition, and stress reduction programs. And if you're interested in joining any of our support groups, you can reach me at emily@cscatlanta.org. Everyone, take care and have a wonderful rest of your week.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.